experience. You reached out saying, hey, we're looking for a new partner for this exposure. Would you be interested in it? I said, yes, but I'd like all of it. I want not just nursing, I want the behavioral health side of it. So that's my fault that you spend time with our counselors when you come over to hang out with us. I did that on purpose. Just because I wanted to give a full perspective of what behavioral health is like, right? There's a nursing aspect to it, which is what you students care about, but then there's so much more to see that happens after that nursing side, basically wraps up, right? Our provider will say, discharge patient A from detox to RTC, and then Sarah's team will go ahead and do that, and technically that relationship ends from the detox standpoint with nursing, but there's that whole other side of RTC that happens. So I'm hoping to shed some more, maybe answer some questions for things that you guys have seen there that help make connections, and then for those of you who haven't seen us yet, give you a little bit of an idea of what to expect. Do you have anything to add before I
No, good to see faces again that I recognize.
Okay. So this is our mission statement. I will not read it to you because it's super long, and I will make you read it right now, I promise. But I put it up here in the event that you wanted to tune me out and just read it while I talk. But what I wanted to share is Lakeside's been in business for 40 years. They're a family-owned company. I'll talk a tiny bit about the history in just a minute here. But we leave together as a leadership team once a year. And in one of those years, early on, we had different work groups kind of putting together some messages about what we do, and then we had an author who worked locally to our company, and she was just going around taking notes, watching what people were doing, and she put together this mission statement and presented it at the end of that advance, and we really liked it. The ultimate message being a couple of things. That we're in the business of recovery. We put families back together, and this is the start of something and not the end of it, right? That there's a whole continuum of care, and that if we're doing our job well, we're setting people up to go back to their communities and have a positive impact on them. That ultimately this family disease means that this person's not the only one affected, and maybe if we bring the solution here, that solution will have a ripple effect and improve the community for everybody. So that's the mission that we're on, very ambitious mission. We couldn't do it without fabulous nurses. What we do is we start with an ASAM continuum of care. 0.5 is basically an outpatient, very infrequent, super casual, maybe you've had a tiny bit of concern around your use. That could be from a teacher at school, maybe a nurse that you're interacting with at a doctor's office or something could have some reason to say, maybe you get an assessment. So what this is going to be, we call that early intervention is 0.5. So that's saying maybe you had a tiny interaction where your use was inappropriate in a public setting, like you got overserved somewhere and someone expressed concern. But it's really just a conversation. It's not necessarily a formal level of care. The level of care that you're going to be witnessing at our program is going to be way over here. Right over here is ASAM 3.5, and most of what we're doing inside residential treatment. 3.7 is that first 5 days. You would call it detox, and that's where Sarah's work comes in pretty heavy. What I wanted to point out here, fully integrated behavioral health means that there's going to be the substance use disorder as well as the mental health component that are going to be intersecting. You won't see it a ton at residential because we're trying to stabilize people first, and it's done kind of, I wouldn't say on the back end, but not as the primary. It's done once we've reached an initial stabilization period, and then we start sprinkling in that mental health aspect of things. Okay, so quick overview of 3.7 and 3.5. So 3.7, subacute detox, medically monitored intensive inpatient treatment. Length of time in detox, roughly 5 days, depending on how bad the withdrawals are, what the substance was that we're using. Does anybody know what the most difficult substance to get somebody successfully detox from is? Any ideas?
Alcohol.
Alcohol is smart because you have the biggest medical threat, right? It's the most dangerous one. The most difficult medication to successfully get somebody detox from is actually benzodiazepines. That's from Dr. Jackson's contributions, actually, and because of how niche-y, there's something so fine-tuning about that's needed for a benzodiazepine protocol that's not done in 5 days. You need probably several weeks to months to get somebody successfully off of a heavy-duty Xanax use. And then I will stop talking soonish to let you talk more about the detox in just a second. I'll throw in here that a new program that even Sarah and I haven't seen take off yet is we just introduced a detox only. So when someone's done with 3-7, instead of stepping down to 3-5, they would go straight to outpatient treatment. So the protocols that Sarah's gonna cover are gonna be specific to patients who are on detox with us, but even the people who are gonna do a standalone detox for 5 days would have that same kind of treatment. They would get that same detox approach. So tell us what 3-7 looks like from a medical standpoint.
3-7, we have 2 protocols, 2/3 protocols at Lakeside. First one is gonna be our alcohol detox protocol / benzos. They're gonna get the same medications essentially for a patient who has a lower BMI under 20 and is over the age of 65. We'll be using Ativan for them instead of Valium. But Valium's our primary medication used to help patients detox off of alcohol and benzos. First day is 10 milligrams of Valium 4 times a day. Second day is also 4 times a day. Then it tapers down 3 times and then twice. And then pretty much like Kat was saying, it's about that 4 or 5 day detox. And then Kat was talking about benzodiazepine patients. So that's when the phenobarbital protocol is going to come into place. It is very, very tricky. So we have a jumping off point for the phenobarbital. We have like 64.8 milligrams 4 times a day. Then it goes to 2 times a day for day 3, and then day 4 is once. I have yet to see us actually follow this, only because the patients are needing higher and higher and higher, more doses of the phenobarbital to get their withdrawal symptoms to subside.
Can I add to that?
Sure.
Just because I'm on the other side of it.
Sure, yeah.
What we see now are patients who have better access to substances that they haven't had before. You can thank the internet for that. The dark web is fantastic. Also, drugs are kind of cheap when they're made in people's garages, compared to like a high quality prescription like Xanax,
yeah,
right?
Absolutely.
So dark web, you can, like similar to Amazon where you and I would buy socks, people buy drugs. And experimental benzodiazepines are one of those things that are commonly used, especially with our younger folks. We have like 4 or 5 patients, 18 right now,
Correct.
all benzo, all recent overdoses, varying parts. Each of these individuals experience like, how would I say it, like a varied amount of physical lingering symptoms from
Correct.
their overdose. One of them can't feel
Numb.
appendages.
Mhm.
One of them actually had, the toxic encephalopathy. She's actually still regaining her walk. Oh, we medically discharged her.
Yes.
Anyway, the point being that we're seeing like more complicated detoxes
Sure.
from that benzodiazepine standpoint. And the phenobarbital has been helpful, but it is really, really very,
It's
it
finicky.
moves around quite
It
a bit.
does.
Yeah.
So the thing also about the phenobarbital, like Kat was talking about, typically we're going to use that for a patient who has used both benzodiazepines and alcohol, because when you are, when you're treating for just the alcohol, usually that Ativan, that Valium's going to kick it right off. It's going to be fine. But like Kat was saying, we get all these fun mixtures of different things, and we need a little bit of help for the receptors in the brain that are used to those benzodiazepines. So when you give them benzos, it's not going to react the same way. That's why we're going to use the phenobarbital, because it reacts differently, or your brain reacts differently to it. Next one's opiate. So opiate detox protocol, we're going to put a clonidine patch on them right when they come in. It's going to help with things that last for 7 days. We're going to keep it there. Typically, we don't give them another one. Every once in a while, we'll continue the clonidine patch for their whole length of stay, but it's pretty rare. And then we talk about Suboxone. So when a patient comes in, they are going to meet with a provider, and they're going to talk about if they want to be taking Suboxone while they're in treatment. And that's pretty heavily,
Yeah,
don't you think? I mean, most people go that route.
Our medical director, who's Dr. Teresa Jackson, she's an addictionologist, and is, we're very lucky to have her. She would refer to it as like the standard, right? The gold standard of care regarding an opiate use disorder diagnosed individual would be to have a number of what we would call post-acute withdrawal meds,
Correct.
as well as the Suboxone being a stabilizing dose for a serious period of time, at least 6 months.
Correct.
Mhm.
So on what would be considered our standard orders, routine orders, there aren't a lot of orders to the opiate detox protocol, again, the clonidine patch, and then we're gonna give them 5 milligrams of Valium every 6 hours. And that's kind of it on the actual protocol. But on, again, what would be like our standard orders, routine orders, we can give patients Robaxin, which is gonna be a muscle relaxer. That's primarily for our opiate patients. Every once in a while we'll get alcohol or benzo patient on it, but in general, the opiate patients are the ones that are in the pain. And then we also give Bentyl for stomach cramping. I have yet to really see an alcohol patient that's got a lot of stomach cramping. So again, that's why it's primarily for the opiate patient. And then in terms of the Suboxone, when do we start Suboxone? How do we know when to start it? What do we do? So it is going to be 24 hours from last use. So that gets a little funky because our patients kind of lie sometimes. So I'm like, oh yeah, I used, I don't know, 2 days ago. And you're like, yeah, no, you didn't. You did not. So it is 24 hours from last use, or a COWS score, which is how we score the opiate withdrawal. Signs and symptoms, observed and subjective, 12 or more. So part of why we do that is because we do not want to send, by giving them Suboxone, we do not want to send them into what's called precipitated withdrawals. You guys know precipitated withdrawals? Yes. I'm going to explain it real fast. Okay, so what precipitated withdrawals? So buprenorphine has let me just read it. Strong receptor binding affinity. When you give a person who is already addicted, they use heroin, but it can, it can be heroin right now. We're seeing a lot of fentanyl. The buprenorphine, which is what's in Suboxone, it's one of the 2 meds in Suboxone, removes and then replaces the heroin, fentanyl molecules that have already been attached to the patient's opioid receptors in their brain, right? And so the buprenorphine only gives you like half of what you're expecting. Does that make sense? So your body, so it says it affects millions of receptors by being deprived of their full opiate agonist. Does that make sense what I'm trying to say? So it only gives you half. So it's kicking off all those receptors and you go into withdrawals fast and hard and it sucks. First time I sent a patient into precipitated withdrawals, it was because he lied. Imagine that again.
To be fair, they're lying because they're uncomfortable.
Absolutely. No, right? I'm not trying to.
No, it's good, but it needs to be said.
Please,
Both of it needs to be said. So yeah, it's a really tricky thing. It's like we work in behavioral health, means the behavior is what needs treatment. Right?
Absolutely.
And so it's really, really tricky to do because we have a ton of maladaptive behaviors that we're looking to eradicate or adjust in some kind of way. One of them is lying or manipulation, and it's incredibly motivated. Absolutely. Out of physical discomfort, aka withdrawal, or in fear of going into withdrawal.
Absolutely.
So yeah, patients are often going to be fudging the truth a little bit. They tend to be more honest with my nurses and my doctors than me because I don't have drugs and Sarah does. And if they get Sarah convinced that their symptoms are bad enough, then they get X or they get Y because some of the protocols are going to be triggered by a certain score.
Correct.
In this case, a patient who's really experienced in treatment will know if I say my use is too recent, then I'm going to be a precipitated withdrawal. I'm going to be hurting more than I'm hurting right now.
And that's what I was going to say.
And they'll be more cooperative.
So the first time I sent a patient in, I cried because I've never seen a grown man curl up in a ball and just cry harder than he did. They know what it's like. They know it sucks. They know it's hard. And he apologized to me. He's like, I lied. I'm so sorry. I'm like, it's okay.
You want to feel better.
Yeah. And I get it. I said, I just feel horrible, anyway. So, like I was saying, a lot of times they know what precipitated withdrawals are. They're actually scared of it. Mm-hmm. I've had multiple patients say, no, Sarah, I don't want to start with Suboxone yet. I don't want to go to precipitated withdrawals. Yeah. And I actually support that sometimes because they know their bodies. Some people, if they take a Suboxone at 18 hours after last use, they still can kind of feel it even. So, something just to pay attention to. Are you good? Yeah, absolutely.
Does Suboxone treat fentanyl as well as it treats heroin withdrawals?
Okay, so
good question.
I'm gonna give like a yes and answer because nobody is doing heroin. Nobody is doing heroin anymore. People may think they're doing heroin, but they're doing pressed fentanyl in a powder form or some other version of that. The only exception to that, I've seen one patient in the last 2 years who was working in a lab and he was basically testing his own illegally purchased prescription non-time release oxycodone.
Yep.
He was testing them for fentanyl, right? Because it'll come up if you test it beforehand. And that was the only reason he was continuing with that. He was like a very clean user, is what I would call that. He was using a very clean opiate. He's the one exception. Every other patient I've seen in the last 2 to 2.5 years is using fentanyl or some version of fentanyl mixed with another substance. Now, to answer your question, when I first started working in the treatment center 10 years ago, we used Librium to treat everything. You were alcohol, you were benzo, you were opiate, you're cannabis, you're crystal meth, you're getting Librium. Like, good luck to you. It was pretty barbaric then. So we didn't have Suboxone introduced till maybe 5 years ago, 6 years ago. And we had Suboxone just on that front end. And then we started leaving heroin behind and fentanyl came in because it was cheaper and easier to get. And that's where we're at today. So we rely on Suboxone a lot more today than we did for heroin because quite honestly, heroin was a faster withdrawal. It got out of the body a lot faster than fentanyl leaves the body now, which is why we have this caution of precipitated withdrawal. We didn't have that same fear when heroin was the issue. Heroin was a lot more processed and a lot less pure, which meant it was an easier substance to treat for medical providers who were writing orders for Suboxone for a detox.
And one other thing I will say is the Suboxone doses that we're giving, our initial titration dose is going to be 2 milligrams. Then if they
It's like a test dose, right?
So if they tolerate that well, we're going to see the patient in an hour and give them another 2 milligrams. And then in 2 hours, we can give them another 2. Kind of like almost like that phenobarbital. Kind of keep giving it to them until their withdrawals subside. But again, our doctors are really good about, seeing the patients. And they will say, okay, I'm going to see this detox patient. You started the Suboxone, thank you. I'm going to see him. Let's give him 8 milligrams now of the Suboxone. See how that works. And we've had patients anywhere from 4 milligrams a day up to like 24 milligrams a day. And some patients decide to take it 1 time a day. Some people take it three times throughout, like 8, 8, and 8. It just depends. So
yeah, the thing I love about that is it can be really specific to that individual's needs, that it's not going to be a custom, like you give all patients Tylenol and they all feel better for the rest of their lives.
Absolutely.
So it can be a lot more specific to how bad or how severe their withdrawal symptoms are.
Correct.
So I'm grateful for that.
Me too.
The problem is sometimes patients will give each other bad advice.
Oh, yeah.
And say like, oh, if you have this symptom, they'll give you, do you remember when we had that patient who kept wanting the promethazine?
Oh, that was weird.
Yeah, that was funny. But they'll give each other like hints on how to get access to better, or what they think are better medications, or they'll fake certain symptoms.
Well, I had a gal today say, I fell in the shower. We're like, oh shoot. So we did instant report, talked with her. She goes, yeah, the last person that fell in the shower got some Valium, so I think I need some Valium. And I thought,
To be fair, she is a benzodiazepine primary. We did treat her just last month. She completed treatment, and we knew bringing her back in was going to be risky because she had some kind of really specific, very difficult to eradicate kind of behaviors like this one.
but they do talk.
Yeah, they do talk.
And so,
Should we start talking about 3.5?
absolutely.
Okay, so that covers basic medicine for 3.7.
Yes.
The provider will see the patient and then say, this patient looks great, let's step them down to 3.5. So every day that they are on 3.7, they are getting rounded on and having very nice notes, which allows us to
they're
fine tune
beautiful.
that process.
Absolutely.
So once they're at 3.5, couple of things to know. So most of our patients are in a gender-specific group. There are a couple of exceptions to this. Full capacity for us right now is at 84 patients, which translates to roughly, when we're full, about 8 to 10 patients for a group, right? So if you're looking at how many counselors I have and how many groups we have, there's roughly 8 to 10 patients working in a process group, and that's basically like their pod, their cohort. They stay working with those folks while they're in that level of care. This time of year, treatment gets small. That means 2 things, like the census goes down, so it makes it a little bit less hectic numbers-wise, like for Sarah's team and for the counselors. But what you also get are like your sicker patients. It's really kind of sad, but what you have are patients who are like, okay, I'm homeless, but it's too cold to be outside, so I'll go to rehab. So you get like sicker patients and families who are like, listen, I love you, but I don't even want you for the holidays, go to rehab, please. It's like we really do get our sicker patients this time of year, which even though the census is lower, the job does not feel smaller. Feels like we're still pretty darn busy, like the patients we just described with the Valium pursuits and all of those things. Okay, so I want to touch into our philosophy a little bit. So this is a text that patients get upon admission. So things to know about Lakeside Milam. We are a medical-based model. Another term for this is a Minnesota model, which means we're 12-step education based, yes, but that happens on the back end. Our primary curriculum is gonna be around abstinence-based education, psychoeducation, and ultimately around the disease of addiction. So this text here was written way back when, like back in the 70s. This doctor here, who's pretty cool, his name is Milam. He put together this book and it talked about a couple of things, one of which was genetic predisposition and the actual disease component, right? So he was the pioneer that said, hey, society, we know you think that this is like a moral issue and that people are just bad for being alcoholics and addicts. I'm here to tell you otherwise. I have science that proves otherwise. And he partnered with Catherine Ketchum and then ultimately with the gentleman who is the founder of our program, his last name is Kester. They teamed up and said, let's do something together. Let's create a treatment center that is for your blue collar people, so that's people like me, people who may need access to treatment services but don't have, like huge budgets at home where they can afford things like Malibu passages on the beach in California, but that deserve better than like county funded detox. It's pretty barbaric treatment down here. We want to be right here, accessible and affordable to people. So they created the model that we have now, which is Lakeside Milam. The price point for a full stay at Lakeside for 4 weeks is $16,000. If you're going to do a little bit of like exploring in the program, our next closest neighbor to us, which is just in Edmonds, that does the exact same length of stay, is twice that number to pay cash pay out of pocket. So exact same length of stay, same type of treatment. We actually have the same caterer, so they can't argue that the food's better. Their beds may be a little newer or softer probably, but they don't have the campus that we have, which if you've been there is kind of a nice perk. But they do have a higher price tag. So there's some things to know about, I guess, about the business of treatment, right? Because you can decide that on if you're going to network or not out of network and what your price point's going to be for the services you provide. So for us, we're pretty blue collar and pretty middle of the road. The disease of addiction, we're going to be educating patients on that straight from the get-go, but we're not always going to tell them that we're doing that. So to be fair, when you're walking in the treatment center, you won't see a poster with this picture on there because it's really hard to get this to come off of the wall in a poster and put it into a good package that patients can just eat up one time and then it be all done with it. The disease of addiction has to be, like, we have to give education on the disease in small, I call it microdosing. Like it's sprinkled throughout all of what we're doing for length of stay for our patients to give them like that constant, regular, but gentle reminder that, hey, you're not a bad person, but you're an unwell person that's just trying to get good medicine right now. And that really helps kind of alleviate some of the stigma that society puts on folks that makes it difficult for them to want to get sober. So that's the point of going through the disease part of it first, to open doors. It's to eliminate barriers so that we can do all of the other education that needs to come next. So the recovery process, this is going to be a poster that you'll see hanging on all of our walls and all of our group rooms. So and I have a point to going over these, I swear, but I really wanted you guys to get a taste for like what Lakeside believes and feels like. So the recovery process is going to look familiar. It's going to look a lot like the stages of change because that's really what it is, just called something different. So when we meet our patients, they're kind of right in here. So it's really, really difficult to get to 3.7 level of care and not know that there's a problem. Like if you're walking into the facility voluntarily, because that's what we are, there's not locked doors at our facility, except for like, offices and stuff. But it's an open campus, right? If you've been there, you know what I'm talking about. There aren't gates, there's not chains, there's not whips, there's not big scary things happening. It's a nice campus you walk on. Patients show up voluntarily, and so I don't have a court order that says you have to be there. Patients have to have some motivation and some buy-in to want to be there or to need to be there. Those words can be used interchangeably depending on what day of the week it is. But ultimately, it's really hard to be surprised when you show up. You wake up on day 2. It's not like, oh, I thought this was the vet. Right, like people know where they're going when they show up to treatment. There has to be some acknowledgement of like pain and suffering and consequences that have come to the surface now as a result of the use of substances. It could be a legal incentive, it could be an employment incentive, it could be a medical incentive, like really bad news from your doctor or a terrible seizure, something along those lines. Ultimately, an individual is going to say, okay, fine, I'm willing to go to treatment today, and that's when we meet them. So just because they're in treatment, they're not very happy about it, right? That's also very fair to say. Like, I'm not meeting anybody on their best day of the week. I'm not meeting anybody right after a Nordstrom sale or right after they went to Disneyland. I'm meeting them because things are going well, right? That's the whole point, behavioral health. I'm meeting people on their worst days and they have no idea that it's probably going to get a little bit worse before it gets better. Thank goodness we have a mission statement that reminds us of that because we've got some time to work with, not nearly enough as we want. So admittance. Admittance is when we really get to start digging into things. That big butt, you see that butt right there in the middle of the screen? And I say it like that on purpose. Because I say whatever comes after your butt is going to really, really smell. It's going to stink. I don't want to hear it. So what that means is at this point in the recovery process, an individual is going to say, yes, Sarah, I have a problem, but I have chronic pain, so I can't get sober.
Yeah.
Right? They're going to have a reason for why uses continue to be justified in some kind of way. Yes, Kat, I want to get sober, but my mom died last year and I'm still grieving her loss and I haven't gotten over it yet. Yes, I want to get sober, but I live alone and I don't have any friends and I don't know how I'm going to do it. So this person really can't separate like themselves, the individual, from their use. It's really hard to see things with hope when you're in the admittance stage of the recovery process. So this is characterized by a lot of like feistiness and frustration. It's acknowledgement there's a problem without the ownership of solutions for that problem. That's why treatment becomes effective, because it's like, oh, okay, something is broken, there is a way to fix it, I don't yet have the skills to do it, I'm hoping to gain them over time. So then we find the the acceptance part of the recovery process. And the way we make this transition is through our next philosophy, which I'll get into, but it's really the understanding of like, oh, the world hasn't changed, but maybe the way I show up in the world has. Maybe the way I see my problems at this point in time has changed. And we do that through a couple of ways. Continuous reinforcement of the disease model, obviously some education on this, a whole bunch of time really helps us in this process, and then we have our other philosophy, rational motive therapy. So a form of cognitive behavioral therapy, which is really, really kind of at the core of everything we're doing, working to help change people's thinking. We can change thinking first, we can change behaviors. There aren't behaviors you and I have or anybody else in this world that aren't motivated by a thought first. That comes from here, right? This is the driver of everything we do. So giving somebody back the power after they've lost it. You don't have a chance at being effective with RET if we're in active use or we're withdrawing, right? Or we're actively craving or we're in the middle of the crisis. So RET becomes really effective with somebody who's stabilizing. They're in a window of tolerance where they're capable of accepting this information and also receiving the actual therapy for it, which is like to help that person wiggle around with the same things they've continued to struggle with. So some people would nickname this like the disease of perception because it's how you see things. And that's really, I say that stands true, right? Addiction is a disease of perception because it's really about how we see the world, how we assume the world is seeing us. The nice thing about RET is we don't, it gives us back the gift that we don't see the world as the world is, we see the world as we are. We don't see the world as the world is. You and I, every person in this room, we see the world as we are. It means we're allowed to have a different opinion on something, even this philosophy, even this little talk. We're allowed to like different football teams. We're allowed to believe in Santa Claus or not, right? That's the gift of RET is like, you can stay the same if you want, but these annoying things over here, these outcomes that you don't like and that motivate you to use are also gonna stay the same. And to give person back the thing control, like give them back the thing that they don't realize they have control over, which is just them. That's the only thing we actually have control over is how we see and deal with said thing, right? Whether it's the Seahawks losing or that you don't want to go to Thanksgiving dinner because you hate your family, right? Whatever this thing is that's causing some discomfort, some anxiety, some angst. You're not doing RET because things are going well. We're doing RET on things that are going to be kind of non-threatening at first. And as that person is gaining better skills and stability in their recovery, and hopefully expanding their support for their life, like making their circle of support bigger when they leave treatment, we can get a little bit more depth with the types of things we're able to do RET on, something a lot more intimate, something where the resentment goes a lot deeper. And then finally, that takes us to our most controversial aspect, which is the 12 steps. I'm not going to read the steps to you. I'm not even going to talk a ton about them. I wanted to acknowledge that they exist. But the truth is, when you're looking at all types of therapy, a huge aspect of what reinforces the goals of therapy is having community support. The one we happen to educate on is the 12 steps. So this is not a specific, this is called like a, I think this is called like a non-specific 12-step model, which it doesn't say alcohol in there, or cocaine, or marijuana, or whatever other substance that people like to put in there. For some reason, that's really, really particular for people who are very new to recovery, that they need to hear the 12 steps, where it says, we admitted we were powerless over our addiction. In the actual 12 steps that are hanging in my lecture hall, it says alcohol, right? And any other 12-step meeting you go to that pertains to that practice, it'll say whatever the ism is that we're looking to use the 12 steps on. So I like to point this out because there's oftentimes guests or visitors might assume there's a religious aspect to the program, and there's not. But this can be controversial or intimidating for people to digest. This is an acknowledgement where nurses and behavioral health counselors can say, oh, I only have so much effectiveness on a person. I only have so much skill. I only have so much medicine to give. And then the ultimate goal is long-term sustained sobriety afterwards, right? That the person has a community and I guess a skill set that allows them to sustain that sobriety, which is not going to be attached to you and I, right? We will have a point of intersection with that person's recovery, and then it ends, and they move on. Having the 12 steps offered to people gives them an opportunity to hang on to a solution that may work for them. So I like to cover all of those philosophies so that we can see that there's more to just a 12-step program. People will give us that moniker. Oh, Lakeside, they're just a 12-step program. No, there's a huge amount of psychodynamic education that goes into it, and 12-step aspect is meant to be something that's done long-term, well beyond what they're actually doing in my building. So actual 12-step treatment, like I actually don't know programs that take people through steps while in treatment. Not that I know of. But people are doing them once they're at a lower level of care and they're back in their home community. So yeah, I wanted to point out, like, if we're going to do some categories as to where the education lives in our program, this is really going to be where they're at. So patients are going to get a variety of both group and individual. There's going to be an MAT aspect that we'll touch on again. The cognitive behavioral therapy, which is the RET, but there's other forms of it as well. And then the exposure. So we do send patients to 12-step meetings. There are times patients prefer to not participate, and we do our best to get creative to work with that too. What we're hoping to do is have people not make up their minds and decide things before they've tried them, right? That's contempt prior to investigation. That's closing doors. We're looking to open them up as much as we can right now to solutions. Detox, educate, stabilize. So recap. Good treatment done well doesn't fix anything, and in fact, we've probably wiggled things around enough that they're a little bit more aware of how messed up they are when they leave, right? I did say it that way on purpose. I don't want people to have the impression that they're fixed when they're done, because 28 days compared to like 30 years of drinking is not a fair match. So we really try to help people understand that good treatment done well is only going to bring better awareness to how messed up things are, so that there's more motivation to continue the recovery efforts. When you read that book, Under the Influence, that I showed at the beginning of the presentation, Dr. Milam's philosophy was 100 days of programming. We give them 28. We're not even close to meeting our own goal of what we would want to have for our patients. There's no doctor's orders or good medicine that says 28 days is the magic number. That's all you need. Doctor's orders right here. There you go. Nowhere. 28 days exists because that's what you can convince insurance companies to pay, and what a family can typically afford if they had to come up with funds to pay for their loved one's treatment. And so we're doing our best to kind of work with the circumstances, right? So we have a continuum of care that gets us as close to 100 days as we can. So 28 days of residential with an action group outpatient, which we'll get to lightly here in the future when we step down to the MAT part of it. And then the rest of their lives from there, right? Like, it's meant to be kind of a step down, gentle process where they're not just 28 days and then you go to work on day 29, good luck. It's pretty barbaric and pretty difficult to ask people to do. And so then I highlighted there in the middle, the actual recovery and step work is meant to not be done until they are out of our building. I'll comment that if you visited us, you may have seen a first step assignment. I don't want that to be confused for like the first step that's on the 12 steps. So a first step assignment is going to be a bit of a biographical journey that the individual is going to take their group on, with an effort there made to receive feedback in a way that's like, okay, I'm this far into my treatment, I'm now available to receive this kind of feedback for you, and I'm asking for it. I want that. So it's a big milestone assignment, but it does not translate to, hi sponsor, my name's Kat, I've already done step 1, let's just move straight on to step 2. Like there's still an intention there that that person goes through a first step with their sponsor. And then how about, do you want to talk about medicine in RTC a little bit, and then I'll kind of wrap it up?
Yeah.
Cool.
So patient is off detox. We get an email from medical provider that says, okay, Sarah, hey, move patient from Kirkland inpatient detox to Kirkland inpatient residential. So they typically then move from the detox wing into the residential side section of the treatment facility. It looks very, very similar, except they don't have appointments to come see nursing. They don't necessarily meet with the doctor every day. And some of them have a harder time with that. So it's a hard thing to step down sometimes when you've been getting a lot of attention and you still really don't feel great, but you're not as sick as you were when you first came in. So we do have routine orders, which again are going to be like our standing orders. So everybody that comes in, we will be able to administer them gabapentin. We can use gabapentin, 300 milligrams TID 3 times a day. You can use that for anxiety, for sleep, for sometimes our docs will throw it in for depression. Again, if a patient's been a high benzo use patient, we have 2 patients right now that are on 900 milligrams 3 times a day. So just trying to get them a little bit more comfortable. Again, it's a big one. They have a lot of anxiety. We can give them oral clonidine, which helps lower that blood pressure. And there is a blood pressure parameter on the med. So if patients' blood pressure is below, oh no, we just give them an above. There is a below as well. Oh, stinker. Oh, 80/50. Sorry. And the above is 160/100. That's when you give the clonidine pill, but we gotta make sure we don't give the pill to an OP patient who also has the package, unless ordered. Hydroxyzine, we give that a lot for anxiety, 50 milligrams QID, PRN. It also helps with nausea, hydroxyzine does, just as an FYI. I got a lot of patients that say hydroxyzine doesn't help me at all, it's a cousin to Benadryl, I hate it. I have another patient sitting right next to him says, I have to come in 4 times a day to get to my 15 milligrams of hydroxyzine. It's the only thing that helps. Perfect. So it works both ways. And then, it's true though. For pain symptoms, we do have the Robaxin that people are able to get throughout treatment, ibuprofen and Tylenol. And then in terms of like stomach issues, we get a lot of that. They've been clogging themselves up, they gotta get it out, and then when they get it out, they have a hard time, getting it regular again. So we talk about poop, it's nurses, we don't care, right? So we give out a lot of ammonium, and then milk and magnesia, it's just your bowels don't know what they're doing, and they're struggling. But we got all that stuff there for you. Nausea and vomiting. So our first line of defense is gonna be sublingual Zofran. I guess you could try the hydroxyzine first, but if someone's like truly saying they're nauseated, we go with the Zofran. The Zofran isn't working. We do have promethazine injection. I think I've had like 1 or 2 patients when they're brand new coming in and they're already vomiting. I just high on with the promethazine. I'm not even messing around with the Zofran. I'm like, you can't let that. But no, it's good though. Just get them. Just make them feel good. You do high out with needles. I think us wearing masks at Lakeside has really helped limit the cough, congestion, scratchy, itchy throat. Do you agree?
Yeah.
So I don't have to give out a lot of stuff for that, but we do have phenylephrine that patients can get for nasal decongestant. It helps a lot. We also give Robitussin for the cough, try and help soothe their throats. We have Benadryl, like if someone's got some sort of reaction or rash or whatnot. We do have EpiPens, but we prefer if a patient is in need, has a severe enough allergy that they need an EpiPen, that they come with their own. But Doesn't always happen, so we do have EpiPens on site. If they do have that bad severe of an anaphylactic allergic reaction, we just ask that they keep it on them. If they have an EpiPen, we just ask that they have it on them. Other things patients are allowed to have on them are their inhalers. That's about it. That's the only thing we're gonna let them have, like, medically on, you know, medication-wise on their person. Sleep aids. Oh, this is a hard one. So we let people have melatonin for sleep. So I get a lot of, oh no, Sarah, I've tried melatonin, it doesn't work. Well, we get drinking too. Yeah. Oh, can we try it without the drinking and see if it helps at all? You're like, oh, okay. Sometimes it helps, honestly, still sometimes it doesn't. So my big spiel to the patients is, we've been beating ourselves up pretty good for years. Please be patient with your body. It's trying so hard. Like, I know that sleep sucks right now, but it will get better. But it's hard. We also give trazodone and Seroquel, not together. You can have trazodone and melatonin, or Seroquel and melatonin, but not the trazodone and Seroquel together. Typically, we'll go with the trazodone if patients have underlying, like, mental health conditions that we are aware of. Then we'll go with maybe like the Seroquel, because that can also, it's only 50 milligrams, not very much, but that can help alleviate maybe some of those anxiety issues in their head as well. And then, do you want me to talk about like MAT?
No, I'll do that.
Okay,
That's good.
perfect. Any questions on that? Like routine orders, standing orders? No? Okay.
Thank you, Sarah.
Yeah.
Okay, so patient finishes a 28-day program. Sometimes it's a little longer if it makes good sense for them to be extended, or if they had a medical LOA in there that we would push that discharge date out. And then we have this MAT MOUD follow-up. So while the patient was in care, if they're depending on their diagnosis, the doctor may have started them on a regimen of MAT or MOUD. You're certain if you're an opiate use disorder diagnosis that you're definitely on the MOUD, medications for the opiate use disorder. I think I got that right. And MAT is just like the umbrella statement, medication assisted treatment. We have MOUD with the intention there of being less stigmatizing than MAT for some reason. That's what the field is deciding. But ultimately, depending on how much stability you appear to have with the doctor, because we're working pretty close with you while you're in care. She's seen you probably at least weekly. She'll set up a follow-up appointment for you for like 2 weeks after you've completed residential, so you'll come back and see the same doctor. Hopefully you're involved in outpatient treatment. Maybe you have a 12-step program that you're engaging in. Maybe you're employed, maybe you're in sober housing, but all of those factors are going to help determine how long that doctor is going to set an appointment to see you again for your next follow-up. So for people who are really struggling, like to develop a recovery community, like you live at home with your cat, that's not a great source of sober support. So she might be seeing that patient a little bit more frequently. If you're doing well, you're in structured sober housing, she might push that date out a little further. Yeah.
Not to be a downer, but just wondering, do you know how many people come back to that appointment?
Yeah, a whole bunch of them.
Oh, they do?
Yeah, the doctor's busy.
Okay.
Yeah, because I'm with you.
Yeah.
If I can play with that a little bit. Yeah, people don't stay sober, and they don't want to sometimes, or the Suboxone isn't as easy to stay disciplined with in a non-medically monitored setting like your home, right, or your grandma's house. So people do fall off, I'll be fair, but when people are active in outpatient treatment or in a 12-step program or in a sober living environment, or maybe even all of those things, then they're more likely to come back. And then we also have this other thing that happens where alcoholic patients are like, thanks, but no thanks. I'm not as bad as all of you people. I don't need all of that. We had one this last week, and so out of, I think 6 people who came in for an MAT appointment that day, MAT MOUD appointments, one of them was an alcohol use disorder person who had acknowledged relapsing. Did I say something funny? Okay, I thought you were laughing at me. Sometimes I speak wrong, and I don't always know. You guys will catch it before I do. The one gentleman who had relapsed was an alcohol use disorder guy, and he's not active in outpatient treatment. Doesn't have a sponsor. He was kind of a special flower while he was in programming. He had some unique features that made it difficult to treat him. And he had relapsed on alcohol and acknowledged that. So the doctor was trying to work with him on a safe plan. Her first recommendation to him was to re-engage in treatment, to have some better eyes on. The idea there being like, hey, if he's struggling or missing a program attendance, we might catch that relapse faster. We might help save somebody's life, especially if they're an opiate use diagnosed person, because it's really easy to start abusing Suboxone or to run out before you're supposed to, and then you're calling us 2 weeks early for a bridge because you're taking twice your dose, and hey, something's funny. Why are we doing that? So the ultimate goal being a stabilizing dose is the dose that you need to have your withdrawal symptoms be at bay. You stay there for a period of 6 months, and then the doctor would work with you. And I'm making it sound cookie cutter right now. It's a lot less perfect than this in real life, right? It's real messy when you put human beings in this. That you're working with them over time to maybe lower that dose, if that's the individual's goal. It's really hard for that individual to be putting themselves intentionally in discomfort, though, if we're being real honest. Like finishing a Suboxone regimen or ultimately getting off of substances altogether when you've been on Suboxone for 2 years is really a difficult process to watch, like all the way step down to 0, 100% across the board. The doctor's only going to do that if you can really prove and show some serious stability. Like you are a productive member of society. That's one of the things she says a lot is you kind of have to really show that you're standing on your own 2 feet and that you're very active in your recovery and that you can handle the stress that you're going to put your body through by kind of gently pushing it into withdrawal just a little bit and lowering that stabilizing dose over time. So that for the gold standard of medications for alcohol use disorder, basically what she would call, does she call it post-acute withdrawal meds? Yeah, so for post-acute withdrawal meds for alcohol, because we talk a lot about Suboxone, she's going to be using a combination of like a gabapentin, and a camprosate, and there's a third one. Well, of course, hydroxyzine and trazodone are in there, but what about naltrexone? Naltrexone, which is also going to be something you would hear called Vivitrol. So then that's kind of that wrap up of the MOUD aspect. So if you come in and you're highly motivated and it's early enough in your treatment, and you say, listen, Dr. Jackson, thank you so much. No thank you on the Suboxone though. I want to be an abstinence-based person. Let's yank this Band-Aid off. Let's make it hurt right now. Let's get me all the way off of everything and I'll get a Vivitrol by discharge. And we do. We have to really push that Vivitrol shot as close to discharge because of how long that fentanyl is staying in the body. But people get that Vivitrol at discharge or just before discharge, and then that puts them out for 4 weeks of overdose protection, usually. It's pretty rare that people are getting a Vivitrol for opiate use right now in that inpatient episode. Most of them are going to be alcohol. Yeah. So the doctor will prescribe an alcohol use disorder like a severe or a chronic relapser. She'll do a Vivitrol. She'll do an injection of the naltrexone and the Vivitrol. And schedule them out 4 weeks from there because that person has proven, okay, all the other stuff didn't work for me. I maintained the best program compliance on an injection form. Ultimately, we do see some opiate patients come back and eventually get to a point where they're doing Vivitrol themselves, but that's a lot more rare. Most of our patients are on a Suboxone regimen. Okay, so that covers MAT, outpatient. Some of you already know it. Is there a question on that part?
What did you say? What was Vivitrol?
Vivitrol. Yeah. Thank you for making me talk about this. I love to talk about Vivitrol. Okay, so Sarah mentioned it a little while ago when she said buprenorphine and naloxone. She said there's 2 medications in Suboxone. There's buprenorphine and there's naloxone. Naloxone is also known as Narcan, right?
Which I can talk about in a second. So go. Good.
Yay! Yay! So we're covering the whole gamut while we're at it. So Vivitrol is going to be an overdose protection, so it's going to work like Sarah described. So naloxone goes into your body, right? That's that second part of the Suboxone. Naloxone is going to go into the body via an injection. It's going to go probably right here,
right over.
Intramuscular, upper quadrant there, and it is going to do nothing to you unless you put opiates in your body. If you put opiates in your body, it's going to say, hey, I see you. You don't go here. Because it's going to bind to receptor sites in your brain like a little helmet. It's going to go and rip out this is that precipitated withdrawal thing. It's going to rip out any opiates that are already hanging out in the brain, rip them out, kick them to the side, and then it's going to put a little helmet on that and say, you don't go here. You can't sit with us. You're not cool here. Which basically means some fentanyl, and it's not going to affect me. I'm not going to have that intoxicating effect, and it's probably going to prevent me from having any kind of interest in wanting to use to begin with, because I know I won't be able to get the euphoric high. The problem is people still try to go in with enough fentanyl to lift that helmet off and try to kick it and override it so that they can get the high, and that's where we get, some people can still overdose on it, even though it's supposed to be an overdose prevention medication. Yeah.
So how often do you have to get those injections?
Every,
28 days.
every 4 weeks.
Okay.
Yeah, and a doctor will typically prescribe that for 12 months. They'll say, okay, let's do a Vivitrol regimen for once a month for a year. Some people stay on it longer, and some people are like, look, I'm good. I've got a job, I've got a relationship that is stable, sober housing. I feel safe to kind of step off of it, because hopefully, and this is back to that message in the very beginning where I said medicine only can take us so far. Right, the medicine that we're using in all aspects we've described is just to make the patient's job of being a patient a little more doable. So hopefully Vivitrol is a part of somebody's story because it's going to keep them pretty safe, but it's not meant to be there for the lifetime. It's meant to get them for like a stabilizing period where they can reestablish a life worth having and hopefully be able to move beyond it and put themselves in a purposeful life where they're not relying on the medication. So I have funny patients because I work in behavioral health, as you know, who say some really funny things as to why they don't want to take Vivitrol.
Oh, it's, yeah.
So I joke at it because I work in a grim area and I have to be able to laugh at some things. And I really wish people were more original. So I've had everything come from, oh, I heard that I can't have an orgasm on this medication. I don't want to be reliant on anything. People will tell me that. No, thank you. I don't want to be on Vivitrol because I don't want to be reliant on anything. One time I had a patient say, listen, Kat, I get out of treatment on Tuesday. I've got this dental appointment coming up Thursday. I'm going to get narcotics for that appointment. I want the free high. So I'm not going to take your Vivitrol. Thank you very much. So you can usually tell a patient's motivation by how they're showing up in an interaction, not by what their words say. But so I can usually gauge that pretty quick, which is why I'm even involved in the conversation, because I know that they've already been a bit dodgy prior to. And they'll say, no, I'm super, super motivated for my recovery. Okay, great, so let's talk about Vivitrol. Oh, no, I won't do that. Like, yes, but. Yeah, I get it. Yes, there's a problem, but I'm not going to do that. Right? I won't take all the recommendations, even when it's coming from Dr. Jackson kind of thing. So, so it's an interesting part of what we do. But Dr. Mark, who was our previous medical director, doesn't have children, but he would, when I'm asking him, how do you talk to a parent about paying the out-of-pocket for Vivitrol, because it's a very expensive medication? And he said, I don't have kids, but I would pay every cent because I believe it will save lives. So
how much is it?
Probably about $1,200 a shot right now.
I was saying 12 to 15.
If
That's complete insurance.
If your insurance doesn't cover it, if you're a cash paid person,
Wow.
which we have an occasional person
It's
who is.
it's rare that insurance won't cover.
Yeah,
Oh,
super
so
rare.
insurance usually does. Oh.
Yeah, insurance usually does. Sorry for that big gasping moment. But for people who are cash pay, because I've had to make those decisions, can I afford to basically provide a sample dose for this individual until they can secure their own resources? Because we're a privately owned agency, right? We don't have any state funds where they get delivered to us to provide the services. They all come from patients' insurance. All the money we make comes from patients' insurances paying us back for the services we provide, or the out-of-pocket check that grandma writes for her grandson Johnny to get treatment today. So it's real money that we're talking about. But if you're talking about tribe or nonprofit, they have completely different rules. They have grants and they have access to large amounts of this medication and can provide it for very little cost or no cost to a person. So the ultimate goal is to make it available to people. So yes, Sarah's right, most insurance companies will cover it. If one doesn't, then we would double down and go with naltrexone. Same medication, but you have to take it by mouth. You have to make the decision to take it every day.
What are your stats on who agrees to take it?
If I was gonna say, well, who wants to take it versus who
Agrees.
who wants to, there's a ton of opiate people who want to take the medication who can't because of the limitations their body's gonna put on them,
Yeah.
right? That we only have so much time for them to be without a substance in their body before the shot's available to them. So there's those folks, which is probably 10 to 15%, I would say. Most people that are doing an active Vivitrol regimen with us are gonna be an alcohol diagnosed person. Numbers, that's hard for me to say, because we have people coming back to the treatment center 3 days a week for MAT and ODT appointments. Some of them are Vivitrol, some of them are gonna be a Suboxone.
Mainly
update.
Suboxone, I think.
Mhm, But the majority are gonna be Suboxone people right now. So probably 30 to 70. 30% of our patients are probably a Suboxone regimen, a Vivitrol regimen, and then 70% are gonna be on a Suboxone regimen, give or take. Yeah,
Is Suboxone lifetime treatment or also like grow?
Good question.
do you want to answer that?
Sure. You can take it for your whole life. Again, it's like what Kat was talking about earlier. It helps you feel better, right? Harm reduction. So you can take some Suboxone and hopefully because of that helmet that we're talking about, you're not gonna be able to take, I say heroin, sorry, fentanyl or any other, you know what I mean, you're just not gonna be able to take any of those. It's not gonna, you're gonna send you in precipitate withdrawals. So if you actively wanna use, you're not gonna be using the Suboxone. You're gonna say, and we get patients like that too, where they'll say, oh, I'll take Suboxone for a week or two in treatment to feel better, but I need to get off it because I want this job, or I need to get off it because of, that's like a big red flashing light for me.
Actually, it was just last week, we had a gal who's not done well in our program before. She came back to treatment. And then she starts telling the doctor, no, thank you, I don't want to be on Suboxone, I don't want to be relying on it. In the past, I've abused it. And I sent the treatment director an email and I said, Bill's AMA-ish to me. And she was gone that night, which means she left with another male patient with the intention of using substances. So she didn't take the Suboxone on purpose because she wanted to get high later.
And that's what I'm saying, big red lights, flashing lights.
When someone doesn't want to take it.
Yeah.
So
But
I
you
hope not.
can,
The answer is I hope not, but
we don't
medicine
want-
right now is like, so what? They're alive. So we'd rather them take
That's
it.
what I say, like harm reduction, if you will, yeah.
I have a question that I don't know if people kind of thought about or not, but say you have a patient who's on Suboxone, she's doing really well and on it, and now they need surgery.
Mhm.
So
I think Dr. Jackson usually plans for something like that.
Yeah. Also with Vivitrol, we give them either a dog tag or like a plasticky bracelet, you know, those plastic, that says, hey, I'm taking Vivitrol, because there are other medications if someone needs surgery. Say you get in a car wreck and you bust your leg wide open, you break your leg and it's sideways, and you're gonna need opiates. But they're not gonna act appropriately. There are other medications. What exactly they are, I do not know. But I have heard there are other medications to help people with pain.
But for the patient who needs surgery, if it's something that's planned in foresight, we have foresight on that the doctor would work with them like on a safe date to stop, and then a plan in the interim. And that's where outpatient treatment comes into. We usually know about, well, we try to work with patients on things like vacations, like leaving town, refills, being in more risky situations, all things that we would want to have a plan in place for. Do we need more of the medication? Do we pause the medication with the intention of returning? UA is going to be really helpful to have in there as well. And kind of going back to, I feel like, you had asked how many people are coming back, because there's also that stat that we don't know what's going to happen with the Suboxone when the patient walks out the door. Dr. Jackson has a number. It's not a nice number on how much Suboxone on the market is basically redistributed. Like, hi, this is my prescription. I'm going to give it to this guy over here. Use that money to buy my drugs over here. That does happen at pretty high and kind of disappointing numbers. But the medical director who's above us all says, so what if it means more people have access to a medication that prevents them from doing an illicit substance or going into withdrawal today? So there's a couple of ways to spin it. But to answer your question, usually if there's good communication around it, it's something that we can accommodate, or the doctor will have a trusted relationship with the patient to accommodate.
The other thing I see is that the doctor, Dr. Jackson, or a provider will work with the surgeon a lot of times, and they'll figure out a plan together, and they'll be really good about like, hey, let's stop the Suboxone at this point. Doc has surgery, and then surgery happens, he has some opiate or whatever you need, and then between both providers then talk, patients involved. So
about 4 days. About 4 days is when, because we also know that you may have heard the phrase that getting off of Suboxone is harder than getting off of illegal opiates. Because it has such a shelf life. It's staying in that body for a long time. So when we have a patient who's getting particularly feisty, like the nurses didn't see me right when I wanted them to see me. Sarah was talking on her cell phone and Jabberjaw's over there. She wouldn't see me for my Suboxone appointment right at 10 a.m. The doctor is like, there's no such thing as a Suboxone emergency. It's usually not until someone's like on their third or fourth day without their Suboxone that they're really going to start to feel those withdrawals. So that speaks to the timing a little bit on when that person would become into that window of concern of like when we're going to see their body start to go into stress without having their Suboxone.
And there's also a 24-hour medication.
Yeah, what you got?
So I might have misheard you, but you were saying something about Suboxone and the job. Does Suboxone show up on like maybe urine tests or drug tests for jobs? And
Yeah.
does that impact?
Yeah,
whether that person can get a job?
If my doctor was here, she'd roll her eyes and say, please prove it. Like, she would say, show me. But for somebody who works with patients who have concerns about things like security clearances and whatnot, they do have concerns about whether or not that'll come up on a UA. It's really hard because you have HIPAA, you have things that protect your privacy as a human being, and you deserve to have that. So Dr. Jackson is like, if that's a company, like if the person's worried about that job, that's not a job I really want to support them having. Like if they need the Suboxone, they shouldn't have to compromise their health to be able to pass UA to get a job. Like to be, like that feels dishonest and feels kind of like something wrong there. So that's the doctor's take on it. I'll be human with you and admit that, yeah, there are patients who are really worried about getting a certain job or keeping their addiction a secret a little longer or in a certain kind of controlled way because they don't want other prospective employers to know. And it's not that the employer is saying we discriminate against this kind of medication, it's that they don't even want to put themselves in a position to ask or find out because it's an awkward place to be or to feel like you're not as attractive as a candidate for a job because you have a dependence, because you have a medical diagnosis that puts you in a position to need this medication. So I think the world has gotten better at that. I would say I'm suspicious of maybe like a safety sensitive position where you're operating heavy machinery or something like that they may say zero tolerance, zero substances, zero anything that could be misconstrued as psychoactive.
I do know multiple, and not this freaks anyone out, I do know multiple nurses that take low-dose Suboxone and have for
Oh yeah, we've
3 or
had,
4 years, and they do really well, and they're not inhibited, they're not impaired, they're not,
Yeah.
so.
yeah, that's a good
It's a
question to ask.
thing, it's real.
Yeah. Okay, so I'm gonna close out our talk here with for
Do you want
just
me to Narcan or no?
you can Narcan us, yeah, Narcan us. Hit us with the Narcan.
Hiya. We know about Narcan,
Yeah.
we know why we use it.
Yep.
Signs and symptoms of overdose.
Cyanosis.
Mad because you took something from them,
Well,
right?
they don't know what they're doing. It's insane. So you do 1 4 milligram spray, and usually they, and like I said, they'll swing. So be careful. When they don't swing is when you're scared, and you're like, oh shoot.
Do it again.
You make so you can
Right, when it's 2.
you can do it every 2 to 3 minutes. Please.
If they aren't breathing, does that not work? The
Works.
spray, the nasal spray.
Works.
It
It
does
works.
work. Okay, just checking.
Good question. It totally works. You're gonna want to get 911 called.
If you're concerned too, there's an intramuscular version. I have an injection in my desk.
Oh, do you really? Oh, I didn't know that. And the last thing I will say about it is if a patient is like, say, I don't know, we had one gal that ended up having a seizure, aspiration pneumonia. She went cyanotic, her breathing was weird. People like, oh, is she having an overdose? I'm like, I don't think so, but Narcan her. I don't get, like, let's get
So
her
you're not
an
gonna
airway.
you're not gonna hurt.
You're not gonna hurt her.
Yeah.
So that's my big thing is if you Narcan somebody and they're not having an overdose, you will not hurt them. Because that's sometimes our concern is like, I don't want to do something. What if I hurt them? Because you'd rather save their life in case they were, right? So, and it doesn't hurt them, so.
Yeah, and I will say
Don't
for any patient that the doctors put on a Suboxone regimen, she will also order Narcan from our pharmacy at the same time. The tricky thing with that is convincing people to pay for it. Like a pharmacy, like you and I would go pick up our medications from a pharmacy and there's usually an out-of-pocket expense with that. There's a particularly high one for an out-of-pocket expense for Narcan.
Yeah.
Yeah, what's your question?
Sorry, it's more of a statement. In your waiting area, the nursing waiting area, I cannot remember the organization, but there is a poster
Yep.
for ordering Narcan.
StopOverdose.org.
And anyone can just
Yeah.
order it, they will send it to you. So if you have
Stop
the need
overdose.
to carry it for anyone.
Yeah. I'm up on the north end, and there's like an annual event the city puts on. It's an overdose awareness event, and they hand out like in handfuls. They'll hand out Narcan, and so I'm sure each community has their own. But up in Snohomish County, where I live, it's like a particularly motivating item for us to make sure people have access to it. And now keep threatening I'm going to wrap it up. Stop talking to you guys. So I wanted to give at least a bit of an overview on what you could expect when you're in our building. If I wrote this up when I originally sent you this version, I fine-tuned it a little bit now that we've got some practice. So We say arrive at 7. End of day is we estimate about 3:30, which is when shift change happens for nurses. Counselors end their day, group gets out at 3. If you want to chat with them for a few minutes after, you certainly can. Nursing students will begin their day observing nursing team and report to the nursing station at that time. Two students will go here, 2 students go there. I think we all go to morning report together, and then we break for the day. Morning report is at 8, which is when we meet with all the other disciplines to kind of go for a plan for the day. Lunch is midday. We want you to observe both things. It says a full day, but I think you actually get more than that. I think it's 2 days each, right?
Correct.
Yeah. Things to know. Parking is up the hill. You're going to be walking in and out of buildings, and it's cold there. Can be cold there this time of year. Cell phones will be collected once roles are established for the day. Once we know who's going where, we'll collect cell phones. That has improved a patient and classroom experience for both of us. I think that's been huge. And if you wanted to purchase a meal there, you certainly can. There's a lot of stuff close by though that you certainly don't.
Good job, Kat.
And one question came up, can you wear scrubs? Yeah, wear your scrubs, that's fine. Sometimes they're really cute and I get jealous you get to wear pajamas to work, but yes, wear your scrubs, do it. Do it if you feel like flexing your cool nursing skills, wear your scrubs. And that's it. I feel like we've wrapped up pretty nicely for you guys. I'm happy to chat with you if there were specific things you thought I really sucked at covering for you, or if you've not got all the information you need, please bring it in.
Absolutely.
Yeah, I think Sarah did a really good job.
So did Kat. She did a wonderful job.
Yeah.